The Heart Demystified. Smarter Heart University and Dr. Scott on AM 970, The Apple.
Welcome back to your Smarter Heart University, and good morning to you. That flowed well. Pop quiz number 3, your answer. What percentage of high good cholesterol in women greater than 60 is seen with women with heart disease? 20%, 40%, or 60%? So this is the whole key. You know, the old school way of thinking was if you had high good cholesterol, and there's really a conception in the lipid world in my training that after we reach, men and women, a certain percentage of high, really abnormally high levels, it may be counterproductive. I tell patients that good cholesterol is the shovels that dig out the bad cholesterol, and you either have working ones or ones that don't work. And a lot of times when we get these huge numbers, high numbers, 80, 90, 100, we see that most of the good cholesterol around is what we call the non-working. We break it down in small and large, and this is the small good cholesterol. It may be more of a lab concept. It may be a real concept. We've yet to really expand upon that. But for everyone out there, 20% of women have high good cholesterol and still have heart disease. And this is actually a large number. They're usually older. They usually have few risk factors. So you're caught unawares. You can have, I just had a patient like that who had an 80 good cholesterol and had a mild blockage 10 years ago and got a stent it progressed despite every bit of usual risk factor reduction to an 80% blockage. She felt only tiredness. That was it. She got a stent and she doesn't feel as tired. They usually have low cholesterol levels. They usually were on hormone replacement therapy protecting them. And in one paper, this led to a conclusion that a redefinition for high HDL or good cholesterol levels in women may be warranted. So stay tuned. We'll let you know if that ever comes out. So last segment, Smarter Heart, is always what you can do about it. And so I call this section to test or not to test, and which test. How do we predict a woman's risk? The current guidelines do a terrible job at predicting danger for women. We call it the Framingham study. It's used by, when you're getting life insurance, they use it. And the insurance companies now kind of use this to determine whether they're going to allow you to have a stress test and allow you to have a catheterization or any of those tests. Well, the Framingham study is 40 years old, folks. And it's outdated. And I will tell you that when they looked at a modern analysis using coronary calcium as a risk, and Dr. Kaiser is going to go into this, 98% of women were told that they were low risk. And in those women, 98%, so almost 100%, they said, all right, you're low risk. You don't need anything. You don't need a stress test. You don't need a cholesterol pill. You're low risk. 30% of them had plaque in their arteries. They had an abnormal calcium score greater than 75%. What does that mean? 75% is
that's a moderate to maybe even high risk of an event in the future.
Okay. So this indicates vascular disease.
It does.
All right. And it mandates aggressive lipid-lowering treatment. And again, these are women who were told low risk, so they were told they didn't need it. They were told to lose weight and exercise, and that's all. And maybe this was the young lady that 10 years ago had the little plaque by catheterization and just wasn't aggressively treated until we got a hold of her. A better study that's not used, and I'll stay politically correct, and I don't know why it's not being used because it darn well should be, is the Interheart Risk Predictor. It looked at 9 factors that we all have and that are typically associated with a heart attack. And what they found was in women, in 90%, smoking, diabetes, high blood pressure, obesity, diet, exercise, and excess alcohol, as well as an abnormal particle ratio. That's where you have too many small particles. I say to patients, that's mud, if you look at bad cholesterol being dirt, and not enough large particles, that's the sand, as well as psychosocial stress. They looked at every one of these factors. Well, guys, isn't that what we have in the world today now? Not 40 years ago, okay? Stone knives and bearskins. This is why we should be looking at the world, this inner heart risk. what it did was it opened up risk to younger people and also to different ethnic groups. And that's what's fair. It's a fair, balanced study from that standpoint. That predicted 90% of heart disease if you looked at these factors and had these factors. The remaining 10% goes back with these biomarkers, the top two that I talked about, the C-reactive protein, the PAC-men in women, or the inflammation or volcano effect, whichever one you want to call it, as well as lipoprotein little a, the evil twin brother. They also looked at the imaging, which that's Dr. Kaiser's area, the coronary calcium scans, and this vascular ultrasound that the WISE study used to stick up the arteries. This is how testing should be done. I'm not really sure how to. I'm speechless.
The Framingham risk is a good baseline, but it's 40 years old. Are we using anything in medicine that's 40 years old? I mean, we always should be trying to advance our understanding of things. And calcium scanning is a perfect example. Framingham risk is just using what are all the different things that high blood pressure, cholesterol, family history, looking to try and predict your event rate. It doesn't tell you whether or not you have disease. You get a calcium score and you have you have calcium in your heart arteries, you have coronary disease.
To test continued, part 2. So what's good and what's not? Stress test. Stress test, because of this maximal exercise capacity, is actually very, very poor. Because if women have the inability to reach this maximal exercise capacity, or anatomically because of obvious chest wall differences, you get this term falsely positive, and it really should be re-examined because it really denies most women who may be at risk the proper and aggressive treatment they deserve. Most accurately is stress echoes. This is where we put you on a treadmill, and at peak exercise, we take a baseline echo ultrasound of the heart, and then at peak exercise, we take that echo again and look at all the walls of your heart from when they're at rest and when they're at peak exercise, and we're able to see if one wall doesn't move as well as another. It actually allows women to be equal to that of a diagnosis of a man in terms of a stress test. Now, on to what we call subclinical disease detection. This is this coronary calcium detection. Why is it important? Calcium in your arteries is an independent risk factor of events, as we just said. It identifies you as a vulnerable patient. But women, however, are more likely to have non-calcified, soft. It doesn't appear on the scans, and they're usually, in general, at lower risk for events. So when women have this, and again, this was this whole Framingham thing that they missed this, it increases your risk. So a calcium score is a very good thing for you to get. Who should get? Well, family history. If you have a first-degree relative with premature disease under 65, you should get it. If you're under 60 and you have 2 or more risk factors, such as high blood pressure, diabetes, smoking, or high cholesterol, you should consider $350 test to get. It's better. We all spend money on different things. So who should be screened? All postmenopausal women. If you have a family history, less than 60 of vascular disease, high blood pressure, or metabolic syndrome, a high sugar. We're going to talk next week. There's no such thing as borderline diabetes. That's next week's topic. Please tune in on your Smarter Heart University. We'll post the rest of this, who should be screened, on the website today. Thank you so much for joining us. Have a great week. And remember, get to it before it gets to you.